Hi viewers, I am Dr.Velsamy Raveendran from Coimbatore, from India. I am very glad to present on knee conditions. Today the problem is exorbitant in India, well, whole world actually, with the knee problems. So I am going to go through some knee conditions which can help the patients for their planning, for their surgery, for their management, and therefore recovery and rehabilitation. Basically, to introduce myself, I actually trained in Coimbatore in South India, which is the textile city of India, and then I left straight away to UK, United Kingdom. Then I was in London, I was in Manchester, I was in Norwich, spent about four and a half years, got my fellowship there, FRCS, and then I left to New Zealand. Very interesting country, I must say, New Zealand. There I stayed for a couple of years, then I went to Australia. Further, I got trained in Australia, got my fellowship there, and then I returned to India. Of course, I've traveled quite a number of places around the world, the whole of Europe, the whole of Asia, many parts of US, and some parts of South America as well. Basically, I want to return to India and serve the people of India. The time I left India, I said I'm returning back for the purpose of the people, to serve for the Indian society. Let me explain some anatomy. It's very important. You have to know what is in the knee joint. Knee is a very, very complex joint. Molangal muttu solra knee is a very, very complex joint. So you have to know something about what is happening in the knee joint. What are the structures in the knee joint before we can think about rectifying, curing them. Very, very simply, that's the front of the knee. That's the front of the knee, what you call the knee cap. Very simply to say, this is the front of the knee, and this will be the back of the knee. Okay, and these are very important structures. This is the knee cap, you call it. Now I'm going to reflect that knee cap there, and then you'll see inside of the joint. Now look at these sides here, this one. Look at these sides here, this one. And all these things which is happening here. These are all the retainers of the knee, the protectors of the knee joint. Now without these, the bone is going to be dummy. The bone cannot do anything because bone will float. Bone will dislocate. It will come out. It doesn't serve any purpose. These are the important structures, all these protecting the knee joint. See some of the ligaments there on the front, and see, look at the meniscus there. That's a soft cartilage. Here, one on this side, one on that side. This is a semilunar cartilage. When you jump, when you walk like all this, it will take the pressure off. It's a shock absorbing unit. And look at this surface here, the dark blue. And look at this one. This is a lighter one. This is bone, and this we call it the cartilage. The cartilage is about 3 to 4 millimeters thicker. And it's very, very important. This cartilage is the lifesaver. I mean that word, lifesaver. From the time you're born till the life goes on, and that's going to protect your knee joint. If this goes off, then the problem starts. So this is the main protector, which is the cartilage, which is going to save the knee joint and protect the knee joint. And all these ligaments there, they have different functions. One on the front, several things at the back. All these are important, and each one has its own purpose to protect the joint. What we call arthritis, there are multiple reasons for arthritis. It's not simple. It's a word arthritis, very, very simple, but there are multiple reasons for it. It can be rheumatoid arthritis. It can be osteoarthritis. So the arthritis will be affecting this part of the joint or the covering of the joint in various spectra. Once it is affected, it goes on to affect the bone. The primary damage happens here. Now this is the normal joint that you can see. There is no damage. I showed you the blue color, you know that. The same blue color exists here. There's no damage here. Okay. Now we're starting to get the damage here. You see the pink color there? And that is starting to get damaged. And as you get to serious, more severe, you can see the damage is getting progressed. And further, you can see how it progresses. I shall show you some real pictures which is taken in the operating theatre as well. You'll be seeing it in the program on how these damages are going to ruin the knee joint. Let me say some fascinating things about knee joint. Arthritis, I told you, it could be due to rheumatoid arthritis. It can be osteoarthritis, which is idiopathic. It can be septic arthritis, infections, very dangerous. It can be traumatic after an injury. So it's very important that you treat the injury properly. Otherwise, it speed up the arthritis, speed up the degeneration. Say, for example, they have a complex fracture of the knee joint. It has to be treated properly. If it is not, the knee joint is very, very uniform, and if it's not, if there is undulations or step of even 2 to 3 millimeters for 4 millimeters, the joint will rapidly degenerate within sort of 3 to 4 years, 5 years. What you are expecting the knee joint to last for 70, 80 years will come down to just 5 years of lasting. So be careful with all the fractures. It has to be treated properly. And there are other reasons as well, which I'm not going to elucidate because they are very, very small numbers. Now it is also fascinating to note in India, it is so much advanced in the knee replacement segment. 20 years ago, when I was trained 30 years ago, it was all done in the Western countries. And we thought that is probably never going to happen in India. I mean, it might happen, but in very, very small numbers. And today, in the last 10 years or so, the numbers have zoomed up. Many, many hospitals are doing the replacements, and highly trained guys are here in India. I'm very, very happy about that. The implants that we use in India is highly sophisticated, highly advanced. Having said that, we also have the Indian-made implants if you want to use it. If you want to, if the patient needs it, yes. Obviously, the cost factor is there. I'll show you a spectrum of the disease that can happen, and you'll have an idea of how the severity of it is. Now, there are so many aspects of the disease, and once I start coming, say, as a surgeon, don't think that I'm going and jumping into surgery. It's not like that. It's not like that. Surgery is the last resort. We have what we call a medical treatment. So initially, please remember, patients, please remember, medical treatment is the best treatment. It has to be done properly, uniformly, and in a way which is being prescribed. If you do follow, majority of the patients do not need surgery. Do you get that point? They don't need surgery. Surgery is only for failure of a medical treatment, which means a failure of the tablets or the injections or the physiotherapy or the failure to lose weight or so many other variables which the patient is not able to cope. They will come for surgery. So we are coming to a very small segment where the patient needs surgery. In the course of this meeting, in the course of this evaluation, you will see so many patients of how they responded after surgery. You may recollect that I've told you the important structures, the cartilage of this of the bone, covering the bone. Now I'll show you some examples of how the cartilage is damaged. And as you run through the first video, you'll see how much of damage which is happened on one part of the joint. The other part itself is okay. So which means that is bone is rubbing on bone. Once the bone rubs on bone, the pain is quite severe. It will not take it. Every movement will cause pain. Walking will cause pain. Squatting will cause pain. Not able to use the stairs. Not able to sit down properly. And in the severity, they are not able to even to lie down and sleep properly. So it's a sequence of events that can happen for a patient, and it can vary from patient to patient. There are multiple reasons as well. As I told you, rheumatoid arthritis. Look at the second example there. So severe rheumatoid arthritis that will just damage the joint completely, the lining of the joint. What is the rheumatoid arthritis in the first place? It's an autoimmune disease. In a common colloquial language, we call it there is a fight within the body. There is no external factors. There is an internal factor within yourself, within the patient, within the joint. It is just fighting within themselves inside the joint. So it's damaging the joint. And the joint is also trying to get protected by what is called an immune reaction. All this forces the joint to get damaged. So when you try to get more amount of tablets, there is a further damage to the system. So there is a limit to the amount of tablets that can be given. And further down the line, the tablets itself are more poisonous. Can I get that again? The tablets itself is more poisonous. So don't take the tablets as simple as one would explain, saying that is innocent. It is not. All tablets are not innocent. Innocent for a degree, for a period, yes, not for long. Once it comes to a certain stage, it has to be done in a different way. See the other case is, case number 3 that you can see here on the picture here. See the amount of arthritis that is developed. So much of arthritis. And these sort of things are not going to respond for any medical management. Let's go on to see what happens if you leave it alone. The bone gets damaged and damaged and damaged further and further. And if you have such sort of a severe pain, you'll see the next video there. And I'll just show you in a second, yeah. In the next patient, there is a further damage to the bone and the joint. Their walking ability comes down. And once we have done a replacement, what is called a total knee replacement, after the assessment of the patient completely in total, which means the cardiac system, the chest, all things has to be reasonably in a good condition for the operation to proceed and to have a good result. It is not surgery alone. The surgery takes just 45 minutes to an hour. It is not surgery alone. It's a post-op that is important for the patient recovery and rehabilitation. So, one of the examples you'll see is a straightforward operation. The patient has undergone a surgery, and after that, look at the way he's sitting. He can squat, he can sit, he can bend, he can walk, just like a normal person. So, once it's done at a good stage of arthritis, not too early, not too late, and in the severity of the condition, where it is eligible for surgery, the patient will do extraordinarily well. It is one surgery for a lifetime. Life is not just lying in bed, lying or sitting in a chair and going on wheelchair. Life is to enjoy. Life is to travel. Life is to walk. Life is to run, meet friends, families. Look after yourself. And don't make the rest of the family depend. Making the family work for you. Don't do that. That is not the way of living a life. You have to take care in the sense when it comes to surgery, you have to undergo surgery. And in these days, the results of surgery are excellent. And if you do come in a reasonable time, they do very well, extremely well. I liked what you saw on this patient here. If you see the next patient, patient number 6, and you can see there that there is a stress fracture. What has happened? They come late. The knee, the hip joint, the knee joint, the ankle joint, all in one line. They are in one line. You can imagine that stress going there. It has to be a perpendicular stress like what you see here. It is in one line. When all goes in one line, like what you see here, one line, can you see that? Can you see that? It is fine. But if it bends in one area, it is bound to get damaged. It's bound to get damaged, and damages more. That is what you see in this patient number 6. They have a fracture there's a fracture below the arthritis. So there is arthritis of the knee joint, and now we have doubling the problem. There is a fracture below the arthritis, and we have rectified that with a different type of implant. You see the other patient here with a further bone loss. The bone gets lost, which means, as you can see from the example here, as you keep walking, the stress goes on one side, there is arthritis, and the bone gets lost. It's rubbing and rubbing and rubbing. So we lose the bone here, and they start bending. You might have seen on the road here, you might have seen on the street, the knee gets bowed or goes into valgus. Either way it can go. So once it's bowed so severely, or the other type of deformity, whatever you want to call it, valgus, the severity gets more, surgery gets bigger, recovery gets slower. Yes, still you will benefit. Patients do benefit in spite of that. Benefit much better than leaving it alone. If you see the next one, with a further bone loss in the patient number 8, further bone loss, see how much of bone loss, and there's a huge that we have to reconstruct the bone, and we have to put an extra prosthesis there. Apart from prosthesis, the cost also goes up. Yes, you will come across to get a bigger implant, there are more additions to be added because of the bone loss, and there's more cost attached to it. If you see some more patients here, how they do well, so severe cases that you see, especially in India, and in spite of all that, they still walk quite well. That is exactly what you saw there on the video now, as it is running. This patient is doing extremely well after such severe deformities. These things are quite common in India. Now, what is the life of the prosthesis? Generally, it's considered to be about 20-25 years, but I have patients who have lasted more than 25 years. First of all, patients maybe even 28-29 years now. So they do extremely well, and the dependents, they are self-dependent, and they can do whatever they want. Having seen that video so far, you might have got convinced that the total knee replacement is a fairly straightforward procedure. And I will show you in the end now how we perform the surgery. Some of the bone cuts that we do, it's very thin cuts, as you can see here. We cut the bone, wherever the bone loss is there, we reconstruct the bone, maybe add with some screws to hold it. It's very important that I want to preserve as much of bone as possible of the native bone rather than putting too much of metal. Metal is not the idea. We want to get too much of native bone. So I have reconstructed that. Once I've done that, then I'm putting the implant inside. So basically what we're doing is like shaving the hair and then putting a cap on. And that's exactly what you see in the running video. Now, as far as the results are said, it's fairly good results, and the patients usually get well-deserved surgery, and they're well convinced. And I get a lot of patients from different areas, and they bring the patients I do more, the patients bring more patients to me rather than anything else. And this is exactly what we need. We have to improve the quality of the care to the patient, and has to be a patient-friendly surgery. And this is, of course, a patient-friendly surgery with spectacular results. Thank you for watching. I'm Dr. Velsamy Raveendran from Coimbatore in India.